So I'm Ronnie Cohn. I'm currently the Chief of Pediatrics at the Hospital for Sick Children and the Chair of Pediatrics at the University of Toronto. And I've had a long-standing interest in muscular dystrophy research over the last 20 years, mainly focusing on animal mouse model type of research, and then switched to CRISPR-Cas9. Let's say within the next 2 to 5 years, I think it will be patients who have disorders that are going to be treated by modifying ex vivo, meaning bone marrow cells potentially outside of the human's body, and then through a bone marrow transplant giving back these edited cells. So these are disorders like blood disorders like sickle cell disease, beta thalassemia, some immunodeficiency disorders. So I think this is going to be some of the first group of patients. Other groups that might benefit from this are patients who have genetic disorders that cause blindness. So where you have to just inject the CRISPR-Cas9 construct into the eye. So as you hear, a lot of what I'm talking about is really related to how you're going to get the CRISPR into a human's body. So I think then after that, we are probably going to see this come to clinic for patients where you can try to administer this maybe to the brain, to the liver, or even to the muscle for certain disorders. I think one of the most important questions that we as scientists and physicians are going to have to answer over the next decades will be, assuming that the technology is going to work, but I think it probably will. What's the therapeutic window for our patients who will receive a certain treatment? And that will be different for every disease. So what is too late in the disease process? And what might even be a bit too early? There are some certain diseases where you may want to wait until certain phenotypes are in place so you can treat it. But the most important question will be, when is it going to be too late? The answer to this is, I think that's what's going to keep us going for the next few years. I think we need to do significantly more in-depth research to really understand whether modifying the gene or the genome of an embryo is really not going to have any side effects. A lot of what people talk about when it comes to CRISPR-Cas9 therapies are the off-target effects. They are statistically fairly unlikely, and fairly unlikely when it comes to a patient. Specifically when you think about a patient who has a devastating, life-limiting disease, might be something you feel comfortable taking on as a risk. Fairly unlikely in the context of embryo gene editing is a different story. So in addition to off-target mutations, one of the major additional risks we don't know much about yet is the fact that CRISPR-Cas9, the Cas9 aspect of this is an enzyme. So it's a protein, which is a potentially foreign protein to the body, although it's coming from bacteria, which potentially people have had an ability to interact with. But there is a risk for an immune reaction that is associated with this, and that could potentially either be a risk for, as a side effect, being harmful to the patient, or just not being efficient enough if the body develops antibodies against the Cas9 and it can't do what it's supposed to do, then the therapy is not going to work. And then the third aspect, which I think as the therapy is going to develop, I hope will go away, is at the moment, if you want to deliver CRISPR-Cas9 directly into a human body, you would have to use an adeno-associated virus vehicle. And some patients or some people in the population have antibodies against it, just native. Second, Once you administer this once, in theory, one injection should be enough. But if you actually find yourself seeing that whatever effect you're having is decreasing, you want to inject again, you can't do it because the body's developing an immune tolerance against it. So these are the major three obstacles at the moment. Many of the therapies that CRISPR is going to be used for may be mutation specific. So if you're going to try to fix a specific mutation, it might be that there's only one or a handful of patients who have that mutation. So I think there is a much bigger issue that needs to be resolved with regulatory bodies as well as industries of how do you figure out to make a drug for potentially just one patient. I think there will be ways around it, but that's, I mean, CRISPR-Cas9 is probably the example of individualized medicine that exists right now. So one of the other big studies that will occur over the next few years are very thorough cost analyses studies that will calculate and compare the following. So if I have a child that has a certain disease, and with that come a lot of side effects, a lot of problems, this child is getting a lot of support and management in the healthcare system that costs a lot of money sometimes. That can be as much as lots of doctor's visits, that can be as bad as being on a ventilator 24/7. And if you take that type of cost over the lifetime of a child that may actually become an adult, these are the kind of costs you then need to compare to the cost of drugs that make these kids better, take them out of the healthcare system potentially, and either significantly or maybe completely. And then you have to start thinking, okay, maybe a child with a disease under the age of 20 costs X million dollars, which would justify that if you treat this child with half X of $1 million, then it's still cheaper for the healthcare system. This is stuff nobody really has undertaken so far because we really didn't have much to think about. But now we do, and we need to fix this. So I think industry, government, hospitals, healthcare systems, insurance companies, they all have to sit together and figure this out.